Hey guys, and welcome back to another video of Keep It Simple Stupid, and today we're going to be discussing status epilepticus. I'll be providing a definition for it, and then I'll be giving a treatment algorithm that should be able to help you get an idea for how to treat this. Alright, well let's go ahead and get into it. Alright, so very important here, again, keeping things very basic and simple. So the important question that you're going to want to know right off the bat is, what is the actual definition of status epilepticus? So there's two definitions for this. One is, it is a single seizure lasting 5 minutes or more in length. So keep that in mind, 5 minutes, very important. And the other definition is that it is 2 or more seizures without recovery of consciousness between seizures. So say someone seizes for 2 minutes, they stop seizing, they're still postictal, aka they're still confused, and then they seize again. So in that instance, even though it wasn't a continuous 5 minute or more seizure, technically they are still in status because they had, again, back-to-back seizures without recovery of consciousness between those two. Again, to make things very simple, this is the definition for seizure that I pulled off some medical textbooks I've been reading. But seizure, it's just an episode of abnormal neurologic function caused by inappropriate electrical discharge of brain neurons. Gold standard for diagnosing this is an EEG, but that is the definition of a seizure. So very important here. Let's go ahead and get into the timeline and then look at the treatment. So say, for example, you are on the medical floor and a nurse pages you because a patient is seizing, or you're in the emergency department and you get a tele from an EMS crew. They're picking up a patient who is coming to the emergency department for seizures. Now, here's kind of the basic timeline. We're going to go through the different lines of treatment, and we're going to start with the first line. So one of the biggest things is you have a patient that's coming in seizing. Obviously, you want to get them hooked up to a monitor. You want to make sure you check a glucose. Very important, because a patient who is hypoglycemic can demonstrate a clinical presentation that could make you think it's seizure-like activity, but maybe they just are hypoglycemic and you just need to give them some glucose. Okay, but say that's not the case and say that the glucose is normal. So this is what you want to do in the first 0 to 5 minutes. So the first line, medication for treating status, these are all in the same classification, and these are benzos. What are the options here? So one important factor to consider is, does the patient have an IV or not? Now, if a patient's on a medical floor, I would assume they probably have an IV, but if they're coming from outside of the hospital by an EMS crew, I think there's a higher chance that they may not have an IV. And the reason this is important is because this is going to help you make a decision on what medication to order first. Now, say they do have an IV. So yes, they have an IV. First line is going to be lorazepam. This is also known as Ativan. That dose is going to be 0.1 milligrams per kilogram with a max of 4 milligrams. Now, if the patient does not have an IV, you can order a medication called midazolam, or again by its brand name, Versed. And this is a medication you'll give the dose of 0.2 milligrams per kilogram with a max of 10 milligrams IM. I was also curious when I was researching the information to make this video is, why is Ativan a better choice for IV versus Versed? And the information that I found was that Ativan has a longer duration of action on the central nervous system, all right? And that was listed as 6 to 12 hours, whereas Versed is 15 to 30 minutes. If you don't have an IV, first line is going to be midazolam / Versed, and if they do have an IV, it's lorazepam / Ativan. Let's go ahead and move into second line treatment. So the patients come in, they've been actively seizing, you've given them either Ativan or Versed, and the seizure-like activity is still persisting. Now, this is where we're going to bump it up and we're going to pick a second line agent. Now, there are way more than 3 options, but just to keep it simple, I just picked 3, specifically the most common ones that I've seen. The first one I have listed here, levetiracetam, more commonly known by its brand name of Keppra. This is a medication I've seen given all the time for seizure-like activity, and that dose is going to be 40 to 60 milligrams per kilogram with a max of 4,500 milligrams, so a very large dose there. Now, if for some reason you can't give Keppra, maybe they're allergic to it. I have seen that. Another option is fosmanitoin, or Cerebrix, which is the brand name. And the dose for that is going to be 10 to 20 milligrams of phenytoin sodium equivalents per kilogram IV with a max of 150 milligrams of phenytoin sodium equivalents per minute. Now, I will explain this because this was very confusing. I didn't even know about it until I started making this video, but I'll explain that in a little bit here. And then finally, another option could be valproic acid, also known as Depakine, a dose of 20 to 40 milligrams per kilograms IV with a max of 3,000 milligrams. As I discussed with fosmanitoin, it's given in this very odd medication dose formulary. Now, if there's a pharmacist watching this, please leave a comment, educate me as well as to why this is the case. But PE stands for phenytoin sodium equivalents. And to explain this, if you have 1 milligram of phenytoin sodium, this is equal to 1 milligram of phenytoin sodium equivalents. And to get the dose of phosphenetone you need, you have to take that amount and multiply it by 1.5. So if you have 1 milligram of phenetone at sodium equivalents, that is 1.5 milligrams of phosphenetone. And another example, so say you need to give a patient 1,000 milligrams of phenetone sodium equivalents, you're going to multiply that value by 1.5, so you give 1,500 milligrams of phosphenetone. Very confusing, but I just wanted to make a quick little note about this because it was confusing to me as I was making the video as well. So now we're at third line, so this is not good. So we've given our benzo, we've picked a second line agent, the patient is still actively seizing. The reason this becomes an issue is if a patient is having seizures for greater than that 5-minute mark, then now they could potentially have neuronal damage. When you get to that third line, the important thing here is that you will want to intubate the patient. 1, for airway protection, and 2, the way I think about it in my mind is you're about to give this patient a third line medication that has the potential to make them apneic, which means they won't be breathing. So you're going to need to protect their airway. Now let's go ahead and discuss some of the third line agents. Now, kind of going full circle here, the first one listed out is midazolam, so our good friend Versed. You could give a loading dose of 0.2 milligrams per kilogram, followed by an infusion of 0.05 to 2 milligrams per kilogram per hour. Another option that I have seen used before is propofol, and you can load them with 1 milligram per kilogram, followed by an infusion of 1 to 10 milligrams per kilogram per hour. A third option here is phenobarbital. You're going to give that at a dose of 20 milligrams per kilogram at 50 to 75 milligrams per minute. Well, I hope that helped clarify what status epilepticus is. I hope I clarified some of the timelines that are important. If you have a patient that is seizing, make sure you're always keeping a broad differential. For example, if you have a female patient who is of childbearing age, you may want to consider something else like preeclampsia with severe features. I'm not going to get into that in this video, but just wanted to make a point of that. All right, that's all I have for you guys today. I hope this was helpful. As always, like, comment, subscribe, and if there's any specific topic you'd like me to make a video on, please let me know. Thanks for tuning in. I'll see you guys next time.